So right. Excellent. Can we all see my slides, please? Just to confirm, perfunctory
Yes,
questions.
yes, we can, and we can hear you very well. This is fantastic.
Okay. Oh dear. So good. Right. Okay. Good afternoon, everyone again. Yes. So today we'll be talking about sort of how CMR helps us in the management of non-ischemic cardiomyopathy. Last week we sort of spent some time discussing how it helps us in ischemic cardiomyopathy, and the first week was sort of laying the grounds for why CMR, the principles of the modality, the science behind it, its utility, the strengths that are intrinsic to the science of it, the physics of it. And then our second week, we sort of went through the technicalities in greater detail, how we can upgrade our existing infrastructure to a CMR capable program. And then last week we went into the details of CMR in ischemic cardiomyopathy. So this week we'll start the first session of non-ischemic cardiomyopathy. So I've got non-ischemic quote and unquote here because in fairness, using sort of contemporary nomenclature, it appears to be a tautology because the only guidelines that exist for the management of patients that have heart muscle disease that is not due to coronary artery disease is this 2023 guideline from the ESC, European Society of Cardiology, where in fairness, cardiomyopathy was defined as a myocardial disorder where the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, severe valvular disease, and congenital heart disease, essentially in the absence of abnormal loading conditions or an obvious trigger for the observed dysfunction. And therefore, in principle, cardiomyopathy as a word already excludes all of this, and we will sort of refer to things as cardiomyopathy for the rest of the presentation. At the end of the day, by the time we see the first half of a sentence where the heart muscle is structurally and functionally abnormal, we are in principle discussing heart failure here. And heart failure is that constellation of, symptoms and signs that patients could present with that is then corroborated by at least one of the following. And this really is the universal definition of heart failure as per the European Society of Cardiology, which is also upheld by the American Heart Association and ACC. The patients always have to have symptoms for us to say they're in heart failure. And therefore, if we scan a patient's heart by whatever modality and we have a structural abnormality or functional abnormality that is not accompanied by symptoms, it's myocardial dysfunction, but not heart failure. So we sort of have these cutoffs for our NT-proBNP to define heart failure and, a few echo parameters and examination findings. But back to this echocardiogram that we sort of saw, I think we saw it last week, and we have a dilated left ventricle, which is, globally hypokinetic to a great degree. The septum is thin, everywhere is hypokinetic. The right ventricle is doing slightly better than the left. There's a bit of pericardial effusion. And the big question is, what is the underlying etiology? Because everything diverges from now in terms of what we do, how we manage the patient, what their risks are, etc., what we do with them and the rest of the family. This patient has terrible LV systolic function, and that brings along its own adverse prognostic outcomes. But the story doesn't quite end there. So I looked through literature for sort of the major causes of heart failure in Nigeria as per contemporary published data. And this is the pie chart that, I could pull together from sort of averaged, population averaged numbers from what the papers published. So we have hypertension still contributing an inordinately large amount of the eventual heart failures we see, and followed very, very closely by cardiomyopathies. And then, it sort of gets more granular beyond that, where we have rheumatic heart disease still contributing a substantial portion, and then pulmonary hypertension, um, ischemic heart disease, which we've discussed, actually contributes just about 10% in Nigeria. And this is a reflection of a combination of our genetics, our lifestyle, and our food choices. Now, cor pulmonalis, strictly speaking, is sort of the common endpoint of all untreated heart failures, and therefore is very, very rarely in a very small population of patients is it a standalone primary pathogen. This 5% still fits back into the rest of the pie. And where did this data come from? So we have this data from all of these published works from academics in the climb, and this is where my numbers came from. So I think this is real. I'd like to highlight the cardiomyopathies. We've averaged it at 20%, and a lot of this is from the peripartum cardiomyopathy in Nigeria studies, the PEACE registry. It is now recognized that there is a PPCM belt in sub-Saharan Africa. Nigeria sits, very centrally there. And this is corroborated by astronomical numbers. Nigeria has the highest number of peripartum cardiomyopathy in the whole world. It's 1 in 96 in Kano. And peripartum cardiomyopathy outside Africa is very rare. It's the first line in every writing, in any published paper of it, is that it's very rare, but it's not in Nigeria. And the reason why I sort of harp on and on about it is because we are very, very likely to come across these patients in our practices. And cardiac MRI could help us, in refining our risk stratification and phenotyping of patients like this. And therefore, the question really that is before us is, what do we do when we have a patient come in with these symptoms? Any of these could be the presenting symptom. And, our bedside investigations like EKG is abnormal. We can hear a murmur. They probably demonstrate an arrhythmia and protracted monitoring. We take a detailed history, which in, non-ischemic or cardiomyopathy, so to speak, a family history is incredibly relevant to what we do next. But at the end of the day, when we put it all together, we're probably suspecting a cardiomyopathy. And then we need to define if they do have one. What would make it a cardiomyopathy? We would see structural abnormalities and also tissue abnormalities. We've previously discussed how cardiac MRI is quite strong and able to characterize tissue, and no other modality really can do it in great detail. I mean, photon counting CT is coming on, but cardiac MRI can do it centrally. So we want to basically define what their function is, what their volumes are, what their wall thickness is. We also want to look at their valves. We want to see what the surrounding structures, what the pericardium looks like. And then when we go deep into the tissue, we want to better characterize T1 time, T2 time. We also want to look out for scar. Do they have scar, late gadolinium enhancement? If they do, how much scar do they have? Where do they have the scar? At the end of the day, cardiomyopathies have now sort of been defined in sort of 5 broad groups, where we have hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, which really is the most prominent subset of a group called arrhythmogenic cardiomyopathy, which could actually have biventricular involvement, restrictive cardiomyopathies, and non-dilated left ventricular cardiomyopathy. For people who have sort of been following the field for a while, you can see that things like left ventricular non-compaction are no longer here. They are not recognized as a distinct disease entity because longitudinal studies have not proven that these patients are different from any of these groups, because they are essentially morphological manifestations that don't necessarily lead to a distinctly different outcome than the broad umbrella of HCM or DCM. And they are now described as within these entities, but not a standalone group. We've gone through that. Like the topic of today's session says, we want to phenotype heart failure. And I use that word very often in my practice, and we all do. And at some point, I was just like, what exactly is it? Like a dictionary or a medical dictionary definition? It basically is how we use it. We want to better define these patients and therefore predict and get ready for their outcomes based by a set of observable characteristics. Those characteristics arise by an interaction of their intrinsic genetics and the environment they live in. That environment includes the internal cellular milieu that the body lives in, the blood pressure, the circulating cholesterol, inflammatory cytokines, as well as external environments like pollution, smoking, etc. And to define cardiomyopathy by phenotypes, like we said, these are the things that we are looking for because this is what categorizes them into discrete groups that have predictable outcomes and have defined ways of managing them. So the role of cardiac MRI then arises because for those different 5 different groups, they actually have typical appearances on cardiac magnetic resonance imaging. And therefore, when we put together that clinical history and what we see on cardiac MRI, we can come up with those phenotypes based on the appearances, wall thickness, function, presence of scar, the pattern of scar, etc. And that determines management and as well as risk stratification. This is pretty much saying the same thing, and the fact that it's not just cardiac MRI that we may use, but it occupies a central role. So essentially, back to why we're here, which is the cardiac MRI of it, are protocols. So the protocol for scanning cardiomyopathy is a lot of institutions have what they call their cardiomyopathy protocol. Like we said, we want to determine what their volumes, function is, ejection fraction. We also want to define wall thickness. We want to tissue characterize, and therefore we will have a protocol that inculcates all this in a timely fashion so that, the service can thrive. And, the CMR protocol that I will go on to describe can be completed happily in about an hour or slightly less. So, we acquire our localizers, start axial, sagittal, coronal, as usual. And then with it, we generate our pseudo views. And from our pseudo views, we generate our short axis stack. Then we generate our standard long axis cines. And having generated a short axis cines here, and the cines are the volumetrics, the ones that play like a video in principle, the ones that look like what an echocardiogram would be. And most people will do a cines generally with the balanced steady state free precession method, except if we have contraindications, like if patients have a cardiac device or of any sort, a pacemaker or loop recorder, and we want to take away the artifact, then we can use another pulse sequence like the gradient echo. We also want to get standard views of the right ventricle, and we've sort of described last week how we do that, but this is just a summary. So at the end of the day, we would have volumes and data to calculate RV and LV volumes at end diastole and indeed through the cardiac cycle, and systole, calculate an ejection fraction that is entirely true, accurate, reproducible, but also the gold standard method for generating these indices. Then we go ahead with tissue characterization. We know that these cardiomyopathies can lead to diffuse interstitial fibrosis, which is where there is, sort of interstitial fibrosis. You don't have distinct, discrete areas of scar, but then when you do T1 sampling, the T1 time is elevated because embedded within the fabric of the muscle is also a lot of collagen, excess collagen, and micro scars. And that's, demonstrates some degree progression, and it's helpful in staging accurately where a patient is in their defined disease process. We also do T2 weighted images and maps, where we're essentially doing, remember our T1 time is longitudinal magnetization, T2 is sort of transverse magnetization, and it's calculating how much time it takes the tissue to lose about 2/3 of it. Now, T2 time of normal myocardium is known, and we know that it is elevated as there's more edema and water within the myocardium. So by getting that data set, we can tell if the myocardium is acutely inflamed or not. A T2 star basically just looks at the free induction decay. How long does it take for all, the entire transverse magnetization, most of it to defervices? It's helpful because it is diagnostic and it's the gold standard tool in cardiac screening for cardiac ion deposition in, patients at risk like thalassemia and patients who undergo recurrent transfusions. So the T2 star mapping gives us an idea because again, normal T2 star time of myocardium is known. And as ion deposits, the T2 star time reduces because remember, we're losing magnetization. And if we just think of it in a simplistic manner, if you have a lot of iron within the muscle, we know that iron in everyday use is ferromagnetic, right? It's, a metallic substance will be attracted by a magnet. And let's assume that every metallic substance is iron, but in this circumstance, it's iron that is being deposited, and therefore the myocardium will very quickly lose its transverse magnetization when there is a lot of iron embedded within the myocardium. So the T2 time reduces. We also want, when we're doing the T2 star maps, to see the liver because we also want to get the T2 star time in the liver. And there are defined thresholds of defining whether there is mild ion deposition in the liver and heart, moderate or severe. And post-contrast T1 maps are basically just like T1. It's done the same way as we did our native T1. The difference is that it's after contrast. Now we know that gadolinium reduces the T1 time. So when we do our post-contrast T1 maps, it helps us to calculate the extracellular volume. Now, the extracellular volume is a reliable index in determining if there is scar within the heart muscle. So you're sort of, because, as we do MRIs, we also want to cross-check that we are being consistent and that we continue to sort of make sense. So everything has to agree if there's a pathology. If we say T1 time is elevated, and if we say there is scar, then scar is collagen and is expanded extracellular space, and there has to be expanded extracellular volume. So our post-contrast T1 maps also help us to calculate the extracellular volume by there's an equation that's embedded in the softwares, and therefore once you put in the numbers as well as your hematocrit from a blood draw, so you basically have to take a full blood count sample at the time you're putting in the cannula, and then by the time you intercalate your native and post-contrast T1 times, as well as what the hematocrit is, it gives us what an ECV is. Now, in conditions like cardiac amyloidosis, where session 5, just a teaser, LGE is abnormal, but because of the way the pictures look, it's blurry. It's not crisp because amyloid basically affects how myocardium responds to relaxation and relaxivity. ECV has been proven to actually be a reliable prognostic marker to follow, especially for patients who are now undergoing the available therapies like, tafamidis and all of that. You can actually follow up with their serial ECV, and generally, if patients are responding to treatment, ECV tends to reduce over time. We tend to acquire the tissue characterization studies in mid-diastole, just so we have, good volume. And it also sort of helps us amplify our myocardium to blood pool differentiation because it's not all scrunched up together in systole. Plus, you also have a bit more time to do that based on diastasis length. Now, late gadolinium or gadolinium enhancement is basically, I think we touched on this first session, third session. It's an inversion recovery sequence where, essentially what we're trying to do is apply a saturation pulse and see how quickly, see how long it takes the myocardium to recover. Sometimes we do a TI scout just to see the myocardium, gadolinium kinetics, how quickly does it recover. And then it gives us an idea of the TI time. And then we want to start taking our images when myocardium is null, and null means black. It means that like in the curves of myocardial recovery, that's when the myocardium is crossing the 0 point and therefore it will emit no signal because it's like zero by magnetization, no signal. We want to image at that time because when normal myocardium is there, abnormal myocardium would have actually recovered because the thing is when you inject gadolinium, it perfuses the myocardium through the, blood vessels and our capillary system. And it has a predictable washout from the myocardium if the myocardium is healthy, because it just basically goes to the capillary bed and the venous system washes it out. But if we have scars, especially replacement fibrosis, where you have sort of chunks and bodies of scar, when gadolinium goes into there, it doesn't wash out quickly, which means that normal myocardium would have washed out, but abnormal myocardium will still be holding onto gadolinium and therefore be white. So when we then scan at that time point when normal myocardium is black, any abnormal myocardium is expected to be white. And that's basically the principle behind it. And then we do our early gadolinium images in sort of the first 3 to 5 minutes of contrast infusion. It tells us an idea, it gives us an idea of edema again, but late gadolinium images are taken in the 10 to 20 minutes after contrast infusion. And, we want to see if there's any scar. And it's the late gadolinium images that we use to basically define scar. Now, going a bit more clinical and intercalating it all, hypertrophic cardiomyopathy is the first of those entities that we'll be discussing. It basically is the most common inherited heart muscle disease. Available series suggest that it's at least 1 in 500 persons, with certainly some other series demonstrating that it is actually 1 in 200 persons. And therefore, if we've ever seen 200 cardiology patients in the course of our practice, probabilistically, we probably have seen at least one person. It's fair to say that there is a lot more hypertrophic cardiomyopathy in our clime in sub-Saharan Africa than in the global north, where most of this data is generated from. And therefore, our own environmental prevalence is expected to be higher. It is defined as the presence of increased LV wall thickness with or without accompanying right ventricular hypertrophy in one or more left ventricular myocardial segments measured by any imaging technique. That is not explained by loading conditions, So if we have abnormal loading conditions, if we remember that the principle of myocardial contractility is Frank Starling's law of physics, where, load, an elastic material will rebound after a load till you breach its elastic limit. Now, if we have abnormal loading conditions such as uncontrolled hypertension or aortic stenosis, that myocardium is pushing against that sort of resistance, and therefore is trying to generate a lot more force to push across. And that is not hypertrophic cardiomyopathy, that is left ventricular hypertrophy related to uncontrolled hypertension or hemodynamically significant aortic stenosis. But if we don't have these obvious abnormal loading conditions and patients come to us with wall thickness more than 15 millimeters in the left ventricle, generally we measure this in a short axis slice and at mid-cavity level in the septum. And if we don't have abnormal conditions to explain this, then, we term this hypertrophic cardiomyopathy. It's fair to say that 40 to 60% of these patients do have an abnormal gene. The most common genes are in the myosin proteins of the contractile element of the heart muscle. I've just put in this picture at the top right-hand corner to remind us all of all that contraction coupling that terrified some of us in physiology and anatomy, but it didn't leave. It's still here trying to, but that's what defines the disease process. It's actually abnormal myosin proteins, which are hypercontractile, that basically are the underlying pathology, because there is a gene mutation in often, using the myosin chain, and that's the most studied. They are hypercontractile, but they also sort of couple with the actin with a lot of force. It's actually that exceeding force that triggers the hypertrophy. And you don't necessarily, in some mutations, you have an excess of myosin chains. In others, you don't have an excess number, they're just hypercontractile. This becomes really relevant because of available therapies like mavacamten and aficamten, which are myosin inhibitors. Now, the success of those therapies is simply because they inhibit myosin. And that means that it's able to relax and you don't have so many chains binding in that hypercontractile and forceful manner. And it's astronomical what it does to hypertrophic obstructive cardiomyopathy because when we enrolled our initial set of patients, you normally enroll them on the tablet and then you scan them echocardiogram this time. 4 weeks later, the two patients that were our index patients basically were in lateral tears. And these are, men in their 60s and above. And they were in tears at their life coming back to them because, now they can breathe. Now they can walk upstairs without being terribly out of breath. Now they can walk uphill. So the science is pretty much secure, is what I'm trying to say. There are also mutations in the troponin and tropomyosin elements. There are also what we call hypertrophic cardiomyopathy mimics. Now, these mimics they meet this definition, but they are not due to a sarcomeric gene mutation. They're actually due to other things. It's my second teaser for session 5. Please make sure you're all there and, let people know as well. But we will go into them. And this is sort of where, cardiac MRI sits in a space that nobody else does because we don't have any other way of telling, especially non-invasively. Of course, if we were able to biopsy every heart without the risks of causing ventricular rupture, septal defects, tachyarrhythmias. If we could biopsy every heart and put it under a microscope, we would know what's wrong. But the thing is, we really can't biopsy every heart because 1, it's not available everywhere. 2, it's not without risks. 3, not every patient will consent to it, even if you wanted them to. And some of these patients are so unwell that, you just don't want to put any further load on them because, if they go into an arrhythmia, you're not sure you can get them out of it. And essentially, we cannot really refine our diagnosis, in a way that we can offer precision care and precise therapy so that the right patient gets the right care. If a patient has hypertrophic cardiomyopathy due to a sarcomeric mutation versus hypertrophic cardiomyopathy due to Fabry's disease or amyloid, how do you know? In the absence of, biopsy, I'm probably doing genetics on everybody and assuming we have that, we really can't refine it any further. But these have 3 very divergent ways of treating them. So I think, this is potentially why if we go back to, I think it was session 1 or session 3, where I showed that global burden of disease data, heart disease continues to occupy an ignoble #1 cause of death and morbidity in adults. But the science has refined over time. And to be honest, now we have more morbidity than mortality. Our patients are living longer. We have the diagnosis, but at least we know we can help them. They can live normal lives and live longer. And that's really what we hope to achieve as clinicians, that we help our patients through the journey of life so they are not overburdened by the diagnosis they inadvertently and unfortunately have. So the strength of MRI in these disease entities that it makes a diagnosis. You don't necessarily need an MRI to make a diagnosis because as we can see, the diagnosis is wall thickness by any imaging modality. You can do it with echocardiography, but we know the limitations of echocardiography. So that we can also define if it's obstructive or not. I must put in a caveat quickly that we can't do Dopplers on cardiac MRI. We cannot tell what the LVOT outflow gradient is, but we can see it. We can see flow acceleration in the LVOT. We can see abnormal anterior motion of the systolic anterior motion of the anterior mitral valve leaflet in the 3-chamber view on cardiac MRI. We can fully characterize the mitral valve if there's mitral valve regurgitation, which often occurs in HOCM. We can fully characterize the mitral valve, the extent of regurgitation by doing sort of, a dedicated valvular assessment of that. But More important, also important, and to be honest, more importantly, when it comes to risk prediction and risk modification strategy, is that we can define if there is scar. We can define where the scar is, how much scar is. We can also see the apex very well, which, as we know in echocardiography, you know, we can easily have an LV that looks like this. Meanwhile, the apex is actually somewhere there and we've foreshortened it and we will never know. But with cardiac MRI, with the fact that we're using, we're defining planes with a magnet, with equipment, not the human hand, it's far superior. The fact that we have excellent signal to noise ratio contrast between myocardium and blood pool means that we see things in great detail. We can define the patients that have apical aneurysms, which tends to occur if patients have mid-cavity obstruction and then the apex sort of balloons out and is thin and is thinned. This used to be the biggest risk predictor or biggest predictor of adverse outcomes in HCM prior to the observation of how much LGE changes the story, simply because those ballooned out thinned elements are the sources of ventricular arrhythmias and sustained ventricular tachycardias. We can see if there is a thrombus in the left ventricular cavity. And at the end of the day, what we're trying to do is accurately define disease entities so that the right patient gets the right therapy, precision care and medicine to our patients, but also prevent sudden death. The commonest reasons why sports people, athletes collapse and die is actually cardiomyopathies, undiagnosed cardiomyopathies. And we also know in our climb, we see a lot of and hear a lot of slump and die. Now, there's lots of socialization around it, but the truth is, Nigeria sits on a cardiomyopathy belt, you know. I have practiced outside Nigeria for all of my career. And when you go to every cardiomyopathy clinic everywhere in the world, you see an excess of patients of African descent than is explained by the societal epidemiology. So you go to a society which probably has a city that has maybe 0.5% population from African descent in the society. And then you go to the cardiomyopathy service in that society, and you have about 10% of people from African descent. So there's an overexpression, which means that, this is something. So that's one way to look at it. Another way to look at it is that the data is also quite secure on that hypertrophic cardiomyopathy, and there's very exciting new signal from dilated cardiomyopathy as well. So, our index of suspicion just has to be greatly enhanced so that we can pick up these patients. For most of the cardiomyopathies, there's a risk calculator because, like we said, the biggest worry in the cardiomyopathy is that these patients are at elevated risks of sudden death. And the reasons why they are those risks is one, myocardial dysfunction, two, higher occurrence of life-threatening arrhythmias, ventricular tachyarrhythmias. So we'll go through a few risk calculators. This is the as yet only validated risk calculator for the management, in calculating risks of patients with hypertrophic cardiomyopathy. This is really old. This was published in the 2014 sort of documents that ESC put together for hypertrophic cardiomyopathy, which was sort of the seed for this 2023 guidelines. There's a few other risk calculators that are coming up, but unfortunately, none has been validated and proven to still be secure across large data sets. And still, we use this. There are risk modifiers that have been introduced in the latest guidelines. So basically, if we have a patient and we've made a diagnosis and we want to get all this data from them, from, our examination as well as echocardiogram of them. This is from the 2023 cardiomyopathy guidelines, and this is a flowchart on risk stratification in HCM. You can see that the indices here are slightly different from the indices here. So on this risk calculator, imaging-wise, we just have wall thickness, left atrial size as a proxy, as a measure of left atrial dilatation, because we know that as degree of hypertrophy and obstruction increases in left ventricle, left atrium dilates, as well as LVOT gradient, which is always an echo measure, plus this. Now, this current flow chart says, has all that. So we still have our outflow gradient, wall thickness, left atrial diameter, non-sustained VT, family history of SCD, prior syncope. But now we're also putting in things in our thought process, like age, systolic function of the left ventricle, as well as extent of myocardial scar. Now, at the time this guideline was published, we didn't have as much data as we have today, but we're yet to have that meta-analysis that pulls them all together. But presently, all the data demonstrates that when we have a heart that has more than 15% of the left ventricular myocardium replaced by scar, they have astronomically elevated risks of ventricular tachyarrhythmias, appropriate ICD shocks, and aborted or not aborted cardiac death. So you see that essentially what this workflow says is if you have a low risk person, but they have these clinical risk factors like systolic function, extent of myocardial scar, you upgrade them one step. Generally, the recommendation or the meaning of low risk means that their 5-year risk of significant tachyarrhythmias and sudden cardiac death is less than 4%, and therefore is a class 2B indication for ICD. They discuss with the patient. There's no randomized clinical trial that suggests you should do this. It's to consider, not must do, is basically what a 2B is. But if you have a low risk person, but they have excess scar more than 15% or abnormal LV function, you upgrade them one step. And then, they're now intermediate risk. It's still a consider, but, discuss with the patient, tell them they're now intermediate rather than high risk. Everything's shared decision making. Obviously, by the time we get to a high risk person, it's a should strongly consider an ICD. And if they have demonstrated tachyarrhythmias and a threat to life, then ICD. So, there's something is not come through. Oh dear. We don't really see a nice 3-chamber like we would want to. Our 4-chamber is decent. We can also see that they've got pleural effusions, a lot more on the right than the left, but certainly that wall thickness is a lot. And, when we measured, it was about 28 millimeters, and we can see the short axis slices in and diastole, and it's still very, very thick. So, this is what, this would eventually be reported as there is asymmetric wall thickness, because we can see that this septum is far thicker than the lateral wall. They should all look like the face of a clock and, equilibrated wall thickness, but it's asymmetric on this side. When we play the cines, we would be able to assess if they have obstruction and asymmetric anterior motion of the mitral valve leaflets. This is just demonstrating what the TI scout and what the null looks like. So I'm just going to, so essentially this is a short axis slice where we have a right ventricle here and a left ventricle here, and the blood pool is somewhere in here and the myocardium is here, but this is sort of at the start of, that lineament has just been given. Everything looks really white. And then when we play through different echo times, we can see how things change. We can see the blood pool go black, and then we can see the myocardium go black. And that's sort of normal kinetics, because we expect the blood pool to null before the myocardium nulls. And then, it gives us an idea of how to set our times for then assessing their, for planning their late gadolinium images. Now, just one slide to show what, we try to say about the prognostic index of a scar. These are patients. This was 5-year follow-up on patients with confirmed hypertrophic cardiomyopathy in Vienna, Austria. And, some of them had ICDs. Essentially, they tried to see, what the primary endpoint was a composite of ventricular tachyarrhythmias, appropriate ICD shock, and aborted cardiac arrest, essentially. 230 patients followed up over 5 years, and we can see that the patients, they actually chose, this study was published less than a year ago. They were actually trying to say that actually 15% may actually be too high, because patients as low as 5% and above are still at really high risk, so that we don't just assume it's 15% and then ignore like patients with less a scar burden. So we can see that people that had less scar, had a cumulative primary outcome less often than people that had more scar. The hazard ratio for LGE in predicting the primary outcome was 6.16. They were 6 times as likely to have the adverse outcomes when the late gadolinium burden and therefore scar burden was more than 5%. And this is just a snapshot to say, what is scar? Scar is when we see some white in the myocardium. We can see a bit there and we can see a lot there. And basically saying that even if it's just this much of scar, which is about the 5%, that's, there's still some risk. Dilated cardiomyopathy quickly is basically what it says. The heart muscle is dilated and dysfunctional. The heart structure is dilated and dysfunctional. The defined thresholds for saying what is dilated enough is, as the numbers given. And again, it's got to be unexplained by abnormal loading conditions and coronary artery disease, which means that if a patient comes in with a big heart that is barely pumping, the first thing really to do is to rule out coronary artery disease, potentially with a CT coronary angiogram. Causative gene variants occurring up to 40% of DCM and in 10 to 15% of patients with other things that we think is not DCM, but it may actually be DCM having the second hit theory, where when exposed to chemotherapy or excess consistent alcohol consumption, or indeed peripartum, the pregnancy process is a stress test. We know how much the blood volume increases and all of that. Then patients who actually bear these variants may then manifest disease because of these second hits. I've mentioned about high incidence of PPCM, and also just to mention that the non-dilated left ventricular cardiomyopathy basically means that with scanner patients, they have abnormal ejection fraction, i.e. low ejection fraction, but they are not dilated. The cavities are not big. We recognize that as a phenotype of cardiomyopathies, and these patients may remain that way or may go ahead over time to express themselves as an established DCM or arrhythmogenic cardiomyopathy phenotype. The other thing to say that has, come to the light with data published in the last sort of 3 to 5 years is that incident or recurrent myocarditis, 1 in 3 patients, 22 to 30% of them actually carry a disease-causing variant. Because we know that these cardiomyopathies actually go through inflammatory phases. Those scars sort of wax and wane in their metabolic activity. And when they are in an inflammatory phase, they are more prone to having tachyarrhythmias. What do we do with cardiac MRI in DCM? It's very similar to HCM to diagnosing stage, but in DCM, we have a bit more that we can pull out of the magnet because they're actually defined patterns of scar that are almost pathognomonic for defined genetic phenotypes. And I think this is incredibly relevant in our climes where we may not have access to genomics as widely as other parts of the world. Because there are patterns that when we see where, like, even in the report, we can actually confidently say this looks like desmoplakin mediated cardiomyopathy. And in the patients that have reported their scans and it was that convincing, their genetics was desmoplakin. So, I think this is one of the big strengths of cardiac MRI really is, in this function. And the rest of it is similar to other cardiomyopathies, prevention of sudden cardiac death. Now, again, risk stratification. In fairness, when we see a patient with a cardiomyopathy, really, and they have abnormal heart function, make a diagnosis. And the next thing really with any cardiomyopathy is, do they need an ICD? What is their risk of sudden cardiac death? If they've come in with a story that sounds like it was a tachyarrhythmia or evidence of a tachyarrhythmia with hemodynamic compromise, they really have a class 1, must do RCT backed up, they should get an ICD. If they have abnormal ejection fraction with their diagnosis, it's a strongly consider an ICD. If they have a high-risk gene, and we'll talk a bit more about what those are, but essentially the question is, how can cardiac MRI help us come to these conclusions quicker? So there are established known disease variants, gene mutations that are high risk. It means that they are high risk for sudden cardiac death, high risk for ventricular tachyarrhythmias, appropriate ICD shocks, and therefore, the way we look at patients with these gene variants is slightly different. It's quite different from the way we look at patients with dilated cardiomyopathy without these variants. And this sort of pulls me quickly to my clarion call about the need for genomics. If we sit on a cardiomyopathy belt, it's almost like we sit on a malaria belt, but we don't test for malaria. Like, can we all imagine how catastrophic that would have been for us all if we didn't have a way to test for malaria and we just treated fever as the same way? And that's almost what it's like. Of course, not to the same degree of, incidence, but similar and more catastrophic outcomes is the fact that we sit on a cardiomyopathy belt, but we really, 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 really need genomics. This is why people slump and die. This is why people are playing football or tennis and they suddenly, because we know that with the adrenergic exertion of exercise, if patients do have a scar, they're likely to have tachyarrhythmias. And that is why in the cardiomyopathy world, we actually have exercise prescriptions for patients with this. You can do this, you can't do this. Now, how do we help our patients, our families, our siblings, our society in Nigeria without the genomics? So I'm really, really making a clarion call here that, I know a lot of us are coming from robust academic institutions. It would be wonderful for us to have genomics services developed. There are centers in Nigeria I'm aware of, and I'm really grateful for, and I'll mention the ones I'm aware of, and I suspect and I pray that there's a lot more. But if we come back to, cardiac MRI, now we say they are typical phenotypes, like some things we see. Now, if we see ring-like mid-wall like gadolinium enhancement, this we basically say, and to be honest, it doesn't have to go completely full circle 360 degrees. If it's there in more than sort of 180 degrees, it's adjudicated in a different study to be equivalent to calling it ring-like. And therefore, we can see that for these patients that have desmoplakin, their annual sudden cardiac death risk is 3 to 5%. And therefore, the predictors of that sudden cardiac death are these. So it means that for these patients, we are not waiting for an ejection fraction less than 35%, which is the standard threshold for people with myocardial dysfunction to get an ICD. We are actually going to recommend an ICD with an ejection fraction less than 45%. And even if it's not less than 45%, but we have a lot of tachyarrhythmias, we will recommend an ICD because we know, the science is secure. There is a full list of sort of the different risk scores on the next slide. And, to save more time, I'm not going to do the same thing for all the disease processes, but we're basically saying, fortunately, a lot of these high-risk genotypes actually have pathognomonic patterns on cardiac MRI, and therefore, even if we don't have genomics, we can bridge the gap with cardiac MRI and proceed from this to risk stratification and recommendation of ICDs with a high degree of plausibility that will be correct most of the time, even if we didn't have the genomics, because the cardiac MRI image genomics is actually very convincing and most times accurate. So this is a slide that just basically tells us about the different risk scores. There's also a DSP risk score. And this is the genomic center that I'm aware of in Kano. And I know that they do whole exome and whole genome sequencing. And, and also I think we're long overdue for a clinical trial and just, a genomic-based study in Nigeria in the cardiomyopathy field, because we now have tools that we can actually use and like pivoting from different parts of the world. It doesn't all have to be homegrown and, all present in our nation, because we can do MRIs and report them remotely, but still get the data to help us serve our patients better and keep our population healthier. So just to say, please cascade screen. If you see a patient with a cardiomyopathy, it's incredibly relevant that we screen their family, first-degree relatives, incredibly relevant. So just describing the Kano Genomic Center a bit more. The Madrid DCM score is actually really good. It's if you have a patient with a cardiomyopathy and, maybe you have genomics, maybe it's expensive, or maybe you are trying to convince the patient that their genomics may be may be positive, or you just want to know what's their probability of having a positive genotype. That's what the Madrid DCM score does. It gives you a probability of a patient having a positive genotype by the different questions it asks you: family history, syncope, EKG, MRI, all of that. I am Russian. So this is one of our patients, right? So this patient was referred to, I wrote down what the summary was, but I think it was basically shortness of breath on exertion, abnormal echo. Now, this is the short axis synesthetic. That left ventricle is huge. The right ventricle is also huge. And we can see that, we don't really have a good pump. It's very, very hypokinetic in both ventricles, and there's circumferential pericardial effusion. So this is what it looks like as you process it through the software, you draw contours to define the endocardial and epicardial borders, and also try to do same for the right ventricle. I should stop here because that's a bit of a pulmonary artery. But anyway, to define the right ventricle. And at the end of the day, you have volumes. And therefore, we have exceedingly high volumes. Indexed volumes in this patient was almost 200 ml per meter squared, when the cutoff is about 90 for her age, for this patient's age group. And we can see like shockingly low ejection fractions, which really are consistent with what we see. It's very low. Now, when we so this is a late gadolinium image, and this is real world experience. It's wonderful to put in pictures from textbooks and, research work, which are optimal and also not out of our client. But the truth is, we are setting up the service. Like, we have a service in Nigeria, and, it's phenomenal work everyone is doing. But sometimes, the pictures are not perfect, but you can still make a diagnosis confidently from them. So as this scrolls through, so that's a two-chamber view, and that's your short axis, the gadolinium. We can see that there's transmural enhancement here. There's subepicardial enhancement, there's subendocardial. And then when you get to sort of the distal cavity, we can see that there's enhancement here, which is pathological gadolinium enhancement. But there's also this hypointense foci. And then when I looked at it because you have a full data set, right? So you can see it in two-chamber, three-chamber, four-chamber. You can see it here in the two-chamber view. And we also saw that those ventricles were very hypokinetic. So it won't be a surprise that there are thrombi, and they indeed were thrombi. And this brings on a different element of risk, because the patient now has some stroke risks attributable to this, because these are cavitary thrombi in the left ventricle. So this was sort of how the report was put together, sort of highlighting everything. The total LGE burden was more than 15%. So without a doubt, risks are super high. And then we try to put it all together by saying there is biventricular systolic dysfunction, extensive fibrosis, typical for genetic cardiomyopathies. Cardiac sarcoidosis is a differential because it's a masquerader. It does anything. Flow indices are demonstrative of advanced heart failure, because for this patient, the index stroke volume was well less than 20 ml per meter squared. I think it was about 10 ml per meter squared. So surely they were well steeped in like stage C to D, sky stage C to D of, they should be verging on shock. And it was important to also highlight that. And late gadolinium, again, the thing with late gadolinium enhancement and its prognostic effect on myocardial disease is that the Kaplan-Meier curves always look like this. It diverges early. They have excess occurrence of all outcomes. However you define a cardiovascular death, heart failure, hospitalization, shock, ventricular tachyarrhythmias, appropriate shock. They all present and demonstrate adverse outcomes. And we can see that when we have a ring like LGE, that risk is even a lot higher than if you had focal LGE. And this was in a body of patients, 1,272 patients with DCM. This is out of China. And they all had ejection fraction less than 35%, and they were sort of followed up for sudden cardiac death-related events. They had ICDs, and therefore we could collect this data. And we can see that, LGE is strongly prognostic. cause adverse outcomes. Arrhythmogenic cardiomyopathy is basically, a heart muscle disease, heart muscle abnormality, where the heart muscle is prone to generating abnormal rhythms. And that's the arrhythmogenicity of it. It's not just arrhythmic in terms of it's the heart muscle that is generating it. Because what generally tends to happen is that there's fibrofatty replacement of RV myocardium. But we now know that it's not just a right ventricular disease, there's also a left ventricular disease. And that's why the current sort of paradigm is to think of these together, like even as they are DCM or HCM or AC or ARVC, it's fair to always think of the patient as what is the primary insult here. The primary insult here is a desmoplakin mutation manifesting with right ventricular dysfunction, fibrofatty replacement, LV dysfunction. That way we sort of see the whole picture. It tends to manifest in the second to fourth decade of life, excess occurrence in men and women. We know that disease manifestation is accelerated by high intensity exercise. And there's actually a subset of arrhythmogenic cardiomyopathy in gene-negative people who do excess high intensity exercise. And this we tend to see in sort of cyclists, Tour de France cyclists. So high intensity mountain off-terrain cycling where there's and this done as a lifestyle. In that subset of patients, detraining them reduces the risk, but also, they have arrhythmic risk and some go on to have ICD. So for the interest of time, I'll just keep skipping. So again, what's that protocol? It's a standard cardiomyopathy protocol. The only addition is that we want to do a fat suppressed fat suppressed sequence, because remember, there's fibrofatty replacement. And therefore, we want to do a fat suppressed sequence so that we can scrutinize the right ventricular free wall to see if there's been that fibrofatty replacement. Cardiac MRI for arrhythmogenic cardiomyopathies is entirely indispensable. The actual diagnostic criteria relies a lot on it. So again, risk stratification, there are known genes. And if we go back to this graphic, we can see most of the genes that cause arrhythmogenic cardiomyopathy are genes in the contractile elements of in the sort of cell-to-cell communication elements of the sarcomere. So, the desmosomes, those connexins, those elements that actually facilitate the heart muscle functioning as a syncytium. Because if there's a mutation, then the cell-to-cell communication is askew, and that's how arrhythmias develop. So you'd see that most of it are in the desmosomes, desmoplakin, desmoglein, desmocolin. These are and plakophilins. These are those connection elements. Now, most people with arrhythmogenic cardiomyopathy would actually have a gene variant, and it's often autosomal dominant inheritance, which means 50% chance of passing it on to the next generation with variable penetrance, because as you can see, penetrance can be affected by how much exercise they do or not do. But I think autosomal dominant inheritance then heightens the fact that we have to screen these families. So this is just the Padua criteria, which mentions essentially, there is a defined criteria of how to call arrhythmogenic cardiomyopathy. There is a criteria also in the, the ESC PDF, cardiac MRI PDF that I shared with us. And that's really what I use every time I report a scan. It's like a consultation, really, when we report cardiomyopathy scans. It's a full-blown clinical consultation, albeit from a distance. So it's slightly, distance being that the patient is not in front of me. So it's slightly more tricky. So I have to walk through every data I have received, EKG, clinical story, which is why it's really relevant that these are sent over. If you're requesting a cardiac MRI scan to us, please put in as much detail as you have, because it helps us, especially when it's a cardiomyopathy question, it helps us to actually see the patient just like you saw them in clinic. And therefore, with that cap on, I can then interpret their images even better. So again, cascade screening, genomics, please. There is an ARVC risk calculator. ARVC risk is actually a lot dependent on what the right ventricle looks like and how much arrhythmias they are having, which is why the Holter, 24-hour Holter, how much PVCs they are having in a 24-hour period is a central part of this risk calculator. So sort of LGE contributes, but to be honest, it's the arrhythmia that drives the sudden cardiac death and the genes. So, What we are looking for is sort of subepicardial enhancement in the left ventricle as well as in the right ventricle, LGE, and that's what our cardiac MRI helps us. Now, because the diagnostic criteria, as you can see, talks about volumes, it's important that you derive your volumes from the gold standard method, which is cardiac MRI. The other thing to say is that we don't really see the right ventricle well in echocardiography, and CT volumes are not, are comparable. But the thing with CT is that for you to get volumes, that's a retrospective acquisition across the cardiac cycle. Phenomenal amount of radiation. We can do it without radiation. So yes. So this is actually a clinical case from recently. The question was whether it was a patient who was having lots and lots of palpitations, and they had um, a cardiac MRI to screen for cardiomyopathy. If we just keep our eye on the right ventricle, and if I sort of bring our attention to this free wall, we can see that at some point, it's almost like it's rolling like an accordion. There used to be a musical instrument that we played as kids that was an accordion. So it's rolling rather than just pushing up and down. Here, we can see it's puckering and rolling. And as we look at the images, we can also see that the patient's having incessant ectopy as we're scanning them. And that's why some of the images look like they snap. We don't have a full diastole. And therefore, part of the report said we might have underestimated their overall function, because if we don't have a full diastole, then we will overcall the LV dysfunction, because, our stroke volume appears less, our ejection fraction appears less. But it doesn't look like it's entirely normal. We did parametric mapping, and this was just a slide to show us what it looks like. We obtained T1 images at the scanner, and then the software sort of, and a T1 map at the scanner, and then the software just reconstructed. I'm moving the region of interest around just so we see how the T1 time changes. If you move into the blood pool, it goes up to like 1400. If you come back to the myocardium, then you have, about between 900 and 1000. I'll just type it where I want it to be. So yeah, if when the myocardium is about, 970, this was normal T1. The other thing to look at is the color chart. This is basically 0 to 3000 milliseconds. Normal T1 times somewhere between 950 and 1050. So we expect a purplish hue, which we have, not deep purple, just around there, which we have. So this patient had normal T1 time, which meant there wasn't diffuse interstitial fibrosis in that myocardium. Now, we also did T2 star. So basically the same thing, region of interest in the septum. We've acquired the right images so that the software, sometimes if we don't acquire, but we think we do, the software will basically tell you these are not T2, and you see that it's not gone across different echo times. But this has gone across different echo times, and therefore it's the right image. And you can see that the line fits nicely, and we have a normal T2 star time. So it wasn't excess iron deposition. There wasn't also diffuse interstitial fibrosis. And we can only say this because the magnet, holds the truth. We did look at the gadolinium enhancement imaging on this patient. There really wasn't any. And this is how we reported it, basically highlighting what leads, to the criteria. They have abnormal RV, so they meet the RVEF criteria. They meet RV volume criteria. They had the synchronous contractility due to arrhythmia, but they also had RV free wall dyskinesia. And basically we said it meets minor diagnostic criteria. So we think it's arrhythmogenic cardiomyopathy with biventricular involvement. We encourage genetic screening and cascade screening of their first degree relatives. Just one slide on athlete's heart versus cardiomyopathy, because athletes have big hearts that don't always look like they are pumping very well. But we have to put so many things together. One is the cardiac MRI. What are the volumes? Now, you could have a big heart that doesn't really look like it's pumping out, it's excellent because you expect an athlete to just be frenetic. But you also have to remember that depending if it's endurance sports, they actually have a lot of volumes for that endurance. So the stroke volume is your, holds the clue. Because even if the overall end diastolic volume is big and the ejection fraction is like 53%, and you're like, oh, I expect it to be bigger, what is the stroke volume? You would realize that in athletes' hearts, they have supranormal stroke volumes. It's just that they have a big heart because of the endurance exercise they consistently do, but their stroke volumes are sort of 120, 150 mils, well over getting to 60 to 70 mil per meter squared. So you are reassured that this is actually a normal heart that is just a bit big because of the exercise. EKG and all of that gives you an idea as well. When you do their MRI, you may have interstitial fibrosis because there is microscars from intense, consistent exercise, but you don't expect things like replacement fibrosis and like abnormal parametric mapping. So putting it all together, CMR for the phenotyping of non-cardiomyopathies, basically we categorize them into, we end up with 5 groups of disease types. I have not mentioned restrictive cardiomyopathies because most of them are infiltrative. They are infiltrative diseases and therefore they are session 5. But, we have distinct CMR markers that lead us to make a diagnosis, phenotype them into their different groups that eventually lead to a different type of treatment, right patient. So this is just a slide saying, let's, encourage a phenotype-based integrated approach, put all their data together, come to a unifying diagnosis that puts it all together, and then, apply the right risk score to what you've seen so that we take people off these red lines and try to get them onto the green line as much as we can. Sometimes the only way you can do it is with an ICD and sort of heart failure therapies. Yes, that's me done. And this was long. Apologies, but hopefully it made some sense. Thank you.
Thank you very much, Dr. Chinekwu. That was really fabulous and really quite expensive, but I feel like you did cover quite a bit. And there are a few questions that I think we do have time to get to. We could maybe jump right into that. Is that okay? I think you do
Absolutely.
want to catch up. I think you wanted to touch upon a couple questions from last week. Do you still want to do that? Maybe 1 or 2? Is that still the case or?
Yeah, Prof, I'll let you decide, like sift through, and then any ones from last week that you think I should answer now, and then we'll go on to this session, and I will send in answers to anyone unanswered, and
Okay.
we'll share it with the participants. Yeah,
Okay, so maybe what we could do is to cover this week's, so make sure we get through this week, and then if we kind of see a bit of an overlap or a bit of time, we can then sort of cycle back to last week. So maybe we probably should do that so that people here this week can get a lot of the questions answered.
thank you.
Okay, right. So I think we could start off with the ones in the Q&A box, and I do encourage everybody that have a questions to put that in so we can get through to them. The first one is from Filisani. From the experience, postpartum cardiomyopathy seems to have prognosis, and sadly, I guess he's saying that they lose most of their patients. So the question is, are there markers that CMR can pick up during pregnancy that can help identify if cardiomyopathy is highly likely among pregnant women once they deliver? A very important question.
Incredibly important and one that is very close to my heart. Can I just request of the person that posted that question to please put in what center you work at? Because, and just, from a perspective of